Welcome to SMA's Southern Medicine Podcast. Practicing medicine in the southeastern United States presents unique challenges for healthcare professionals. The South's heavily rural population and limited resources require medical professionals to be more resourceful in their approach to providing quality care. SMA's Southern Medicine Podcast addresses these issues by drawing on the experience of healthcare leaders who provide a multi-specialty, interdisciplinary team approach to medicine for the purpose of providing better care for the Southern patient population.
Thank you all for coming back for another episode of the Southern Medicine Podcast. Today we are joined by Benjamin Smood. Benjamin has history with SMA as he was the recipient of the 2017 Society of 1924 Scholarship. He is currently a resident at the Hospital of the University of Pennsylvania.
So Ben, thank you for joining us today. If you don't mind, give us a little background information about yourself and what residency program you are in.
Alrighty, thanks for having me. So I'm a second-year resident in an integrated cardiac surgery program up in Philadelphia in the University of Pennsylvania. Just finished up medical school down at UAB in Birmingham back in 2019. So yeah, that's where I'm at now.
Repping the Alabama, I like it. So
yeah.
So how has COVID-19 affected your residency program and your education?
Well, as a surgical resident, just about all elective cases were eliminated starting in mid-March to April, and so that obviously takes a toll on how much you get to the OR and training in that respect. In my perspective, it has a little bit of a larger impact on more senior residents who are trying to finish up their case logs and get the numbers they need to go out and be competent practicing surgeons on their own. As far as my personal education, we ended up getting transferred over to a COVID ICU unit in mid-March and spent about 3 months there as things were getting a little bit, as the virus was picking up a little bit more. So it was actually, as tragic as the situation is, it was a good learning experience because it was a lot of critical care, a lot of ventilator management, a lot of vasopressors, and just learning more about the disease each and every day. Because at that time, all that we really knew about it was what we had heard from international studies or small cohorts that had been published in Europe and elsewhere. So it was a really good learning experience when it was first happening. It was obviously scary. We didn't know what to expect, but overall, I don't feel like my education was hindered or hurt by any means. If anything, it was somewhat beneficial to it.
Yeah, so that was looking for what you brought up about, having to, with the elective surgery stopping and you having to kind of shift your focus more to a COVID care team. We actually did a podcast probably back around when the virus really started picking up with a resident in Connecticut, and him talking about his experience being near the New York City epicenter when it was really bad then, about how he was a surgical resident himself and how he had to basically stop all he was doing, and it was just more of a all hands on deck situation to help create the COVID relief team. Is that what you were seeing where you're at, where everyone just is stopping what they're doing and just trying to help out where they can?
Yes and no. So I think fortunately Philadelphia was not hit nearly as hard as New York for a number of reasons. And I also, we had prepared as though we were going to face that scenario. So, units were being converted over early to make way for overflow COVID patients. And in this respect, everything the entire infrastructure of the hospital system shifted its focus for figuring out how we were going to use ventilators or how to care for these patients or how to get enough negative pressure rooms. So yes, to some degree. Fortunately, though, we didn't ever reach that sort of surge capacitance in which we didn't have the resources to care for patients. In preparing for that, everyone did their share. Like I say, myself and the rest of the surgical residents ended up going and spending time in the COVID intensive care units. I appreciate that our program directors were very cognizant of the fact that, we didn't know much about this virus at the time, and still many questions remain. As much as we were important to carrying out the functions of the hospital in this sort of new paradigm, our program directors made a concerted effort to make sure that we stayed safe. By that I mean it was either scheduling in which some residents would be on for a week and off for a week, or maybe every other day to limit exposure. And so, yes, it was all hands on deck, but fortunately didn't ever get to the point in which we were overwhelmed like other places have been.
Yeah, well, that's good to hear. So, quick side question, as we've seen across the country, especially the beginning stages of the pandemic, and I believe you said it, but were y'all able to still have adequate amount of PPE to deal with the patients coming in?
With the measures we took, yes, but I think it really underscores just how fragile our healthcare system is, even in the most powerful country in the world, that we were lacking, and programs across the country were. So as far as PPE goes, we would have to rewash our goggles and use them multiple times. Our N95 masks, we at first were asked to wear them for a day or two at a time, and then that got extended to a week, and then you had to wash them with UV or sterilize them with UV light. And so, was there adequate PPE? Working within the confines that we had, yes. Do I think that did we ever jeopardize patient care? No. Did we ever jeopardize provider safety? No. But I think that we would all prefer to use a new mask or new goggles if we had the opportunity to. But that's maybe unique to my experience. We were at a relatively well-to-do institution with lots of resources and many efforts that were taken to make sure that we had everything that we needed, whereas smaller programs around the country certainly did not. I remember my dad's an emergency physician out in Oregon, and in the early days, they ran out of gowns for providers within a couple of days or weeks. And at one point, they were using either trash bags or patient gowns that had been washed with the linens, and using that to protect themselves as they were having to intubate people. So on a national scale, the simple answer is no. We didn't have enough resources, and there's still questions about whether or not there is adequate PPE. But my personal experience was that I never felt my PPE was lacking to the point at which I was unsafe, or my coworkers were unsafe.
So your dad was one of those people that we saw on the news, having to take the extreme measures of making their own PPE when things were run out. That was probably one of the most shocking things I saw, was just the measures that healthcare professionals had to take just to protect themselves due to the inadequate resources that the hospital couldn't, handle due to the pandemic. So, how do you think COVID has impacted the future of your residency? And as we saw at the beginning as well, and like you said earlier in the podcast, the surgeries were canceled, due to COVID. So has that restarted since then?
Yes, surgeries have restarted. There are obviously precautions in place. Everyone gets COVID tested before they go to the OR. If they are not, their results aren't back, and there is an emergent or urgent procedure. We treat them as if they are COVID positive, meaning they go to a native pressure operating room. All the staff wears an N95 and PPE throughout the procedure. You don't leave the room until the case is completely done. So that means that we have one nurse sitting outside who can go and grab materials and bring them into the room just to limit exposure. But for the most part, at least in my program, elective surgeries included, have gotten up to, I would say, 80% capacity. In some circumstances, 100%. How that affects my residency going forward, we actually spoke with the Thoracic Surgery Directors Association not long ago with regards to how COVID-19 will impact trainees, particularly graduating trainees. Because as I said, the earlier folks, it's an 8-year program, 6 to 8 year program. And so the people in the years 1 and 2, if you hit a bump in the road early, it's not necessarily going to affect your long-term training. But the folks who are really trying to get their final case numbers, that potentially could be an issue. And so what the boards, surgical boards across all specialties have really said is that they're not going to lower the standards for graduating competent board certified surgeons. But if you are short on some of your numbers that you need to get, then there will be flexibility, and it will be a discussion with the American Board of Surgery or Thoracic Surgery or whichever governing body. Generally speaking, it will be a discussion between them, the program director, and the surgical resident about how exactly they will be able to graduate on time, or do they need to extend their training for an extra 3 or 4 months? Because what they're not going to do is they're not going to allow someone to graduate who's not competent or qualified for whatever reason, whether that's because they were delayed in getting their cases or not. Fortunately, though, that doesn't seem to be the case for most individuals. Either A, they have already completed and meeting all their mandatory requirements and they are competent and in good standing to graduate on time. We actually just done a survey with all thoracic surgery residents in the country and gotten a pretty good response out of it, response rate. Most folks didn't feel like this was going to hinder them in the long term, or it was going to delay their training. While it's an inconvenience in some respects, and as folks in surgery, we want to be in the operating room, you got to look for the positivity. Like I say, we're dealing with a really largely unknown disease, or we were at the time, always getting new information on it. It gives you a chance to revert back to some of those critical care skills that maybe you had less experience with in your final year of training, as you're trying to spend more time in the OR. And then learning how, as trainees, we have to react. First and foremost, we're in this to be medical providers, and so that title doesn't stop at operating. There's a whole load of patient care, whether or not you're in a pandemic, that involves critical care outside of the operating room. So I really don't think it's going to affect training all that much moving forward.
Well, good. That's good to hear. So, quick side question on your residency. I have a cousin. She was a professional student probably for over 30 years, and she ended up being a plastic surgeon in Nashville now. And she has like her favorite things to do, like she likes to do in surgery. Are there any things that you are finding that you like about surgery, and or like what's on your bucket list of things to do in your residency?
Well, when you're a first year or a second year and you realize that it's an 8-year program, it seems like it's a lot of time, but the reality is it's really not. If you only have these 8 years or so to learn everything you need to know to go out there and be a competent surgeon on your own. And so while it seems like a long road, it's really not. And just taking every day to try and learn something new to refine the skills that you already have is important. As far as what my favorite things are in surgery, obviously I like cardiothoracic surgery because that's what I went into. Fine transplants are really quite amazing. But to be perfectly honest, most things in surgery are quite remarkable. What we are able to do to the human body, improve the lives of other people, is quite remarkable. In cardiac surgery, you think you stop a person's heart, you put them on a machine that acts as their circulatory system, the heart-lung machine, and then at the end of the case, you expect that you'll be able to restart their heart, close their chest, and they will go on to live a healthier life. So as far as bucket item lists go, no, I think that you need to recognize that you don't know what you don't know, and you haven't experienced what you haven't experienced. And part of residency is taking every opportunity you can to see something new, to see a new person do something you've already seen. Every surgeon will do the same operation just slightly differently, and those are tools that you can have in your repertoire when you need them. So nothing necessarily on my bucket list, but I wake up each day and feel very fortunate I had the chance to do what I get to do.
All right. So last question, and then we'll wrap this up. How do you feel COVID-19 has really altered the future of medicine in general?
It's a good question. As mentioned earlier, I think that we certainly recognize the fragility of our healthcare system and how we need to be more prepared for pandemics in the future. You know, as bad as COVID-19 has been, it could have been much worse. It's a tragic illness, but it's not like we have an Ebola pandemic breaking out now. At least what we have is somewhat containable with the right measures. And fortunately, a large number of people who do get the illness may not necessarily end up, with certain mortality. So we need to be prepared moving forward for as bad as COVID-19 was, if we experience or witness something worse. So that's number one, I would say. Less related to that is kind of looking at silver linings again. For a long time, there have been discussions about how to improve access to care and quality care through telemedicine. And its acceleration was always kind of stunted or slow to be widely accepted. And I think that COVID-19 has taught us that it is an extremely valuable resource and an extremely efficient way to see patients in many circumstances. And I'll be interested to see how that remains in place, or if it remains in place going forward. Particularly, in rural communities, do we need to be having someone drive an hour and a half to see a specialized doctor when you can do a consult over a video conference? I also think that, more broadly speaking, health insurance is an interesting concept that we can discuss with regards to this. So much of this country, so many people in this country have their health insurance tied to their job. Ask the people that who have been furloughed or laid off or are not able to work because of the pandemic, and they have lost their health care because of that. And so I wonder if we will find a shift or see a shift away from employer-based healthcare to another health insurance system, whether that be single payer, whether that be health savings accounts, whatever that may be. But there are larger reaching effects on medicine in general. So do I think that, the actual practice of medicine has changed much? No. Each day, the goal is to improve and make the patient healthier using the best evidence possible. And that, sort of mission hasn't changed. Whether or not the infrastructure surrounding how we administer that will be impacted in the long term, I think remains to be seen. But I would be surprised if there weren't at least some changes that were lasting moving forward.
Well, Ben, I really appreciate the time you spent with us today discussing your experiences with the pandemic and your residency. Maybe once everything has settled down, maybe we can meet up again and discuss how things are going post-COVID-19.
That sounds great. I appreciate you having me on to discuss the current situation. Thank you very much.
Thank you for listening, and stay tuned for more Physicians in Training podcasts. To view all of SMA's podcasts, visit sma.org/podcasts.